Hello, everybody. Hi, Dr. Jordan, and welcome. Thank you so much for sitting down with me today.
Thank you for having me.
This is so exciting. So, if you haven't yet met Dr. Jordan Robertson, you need to meet her today. She is the author of an awesome new book that I have been recommending to my patients. It's all about how to take practical steps to reduce miscarriage risk. It's called Carrying to Term, and it has its own Instagram feed, and you can get it on Amazon, and I highly recommend that you check it out. Dr. Jordan Robertson is a naturopathic doctor and an associate faculty member at McMaster University. She has published 12 review articles on standards of care in naturopathic medicine and is currently the naturopathic doctor for the endometriosis clinic at McMaster Hospital. Her clinical practice supports women with hormonal imbalances from PMS to PMDD and infertility. And she has a special interest in bioidentical hormone replacement therapy as a treatment option for hormonal concerns, as you will read about in her book, Carrying to Term. In her role at McMaster University, Dr. Robertson teaches 2 undergraduate courses on research, and she regularly lectures at McMaster Medical School on research in integrative medicine. This woman is super accomplished. She has also lectured on miscarriage prevention and for NFH's Women's Health Symposium on PCOS and how it relates to fertility and miscarriage. And she has presented at the Ontario Association of Naturopathic Doctors Convention for the last 2 years on PMS and PMDD, premenstrual dysmorphic disorder, and PCOS and infertility. As I mentioned, she's the author of a brand new book, Carrying to Term. And in that book, she's got a collection of the science on how women can reduce their miscarriage risk through diet, supplementation, and medication, and gives women an awesome resource to better understand how to be tested and treated properly for miscarriage by their practitioner. So it's a very empowering resource. You can get it in a paperback, ebook. Amazon is where you can get it online. Thank you so much, Dr. Jordan, for being here. I'm so excited to talk with you today about your book and about our shared passions around just really good women's health and really good assessment for women's health conditions. We met through Instagram.
I did.
Because, well, first of all, your feed is awesome, and it's one of the most salient evidence-based feeds around women's health, and it's really kind of badass. I remember you made a post something around like putting 10 pounds of muscle on a woman turns her into a different metabolic machine. And I was like, this is a doctor that I want to listen to. This is awesome because it's so empowering. So can you tell us a little bit about your story and why did you write this book?
Sure. So, and I do talk about this pretty frankly in the book. I do have a personal experience with miscarriage. So when I was in my final year of naturopathic college, I actually got pregnant every single time I ovulated for an entire year. And so I experienced 3 miscarriages that sort of led me to be sort of swept along with the sort of conventional medical approach to miscarriage and infertility, meaning that I had the 20-hour ER waiting room visit that, some, cold nurse gives you an ultrasound and tells you that your baby isn't there. Mm-hmm. I had that whole experience while I was in school and while I felt like I was learning how to be sort of the healthiest version of myself. I was experiencing this. And I, with the second miscarriage, it happened during the week of my board exams. Literally 3 days before I wrote my licensing exams, I miscarried. And then after the third time, I finally realized that just not doing anything wasn't working, right? That just waiting for something to naturally be different than those first 3 experiences, that wasn't working for us. So we bought a dog. We do the thing that we bought a dog. And I begged my family doctor for progesterone suppositories, which he didn't believe in at the time. And ended up having to really change what was going on with us so that we didn't have that experience again. Like, it actually fell in our lap to be the sort of the impetus for change in our fertility path. It wasn't from, information we were receiving from my healthcare practitioners or even my naturopath at that time. So it kind of made me interested in the topic from a personal perspective. My background is in sort of evaluating medical literature. So my undergraduate degree was in critical appraisal, we call it, which is reading literature and finding out if it's true or not, if it's right or not. So I have the skills basically to become an expert in anything I choose to. And I focused on miscarriage because I'd had that personal experience, and I felt like I had to get to the bottom of it to figure out why it happened to me. And I needed to understand like where the gaps were in care and why for an entire year was I just sitting in an ER waiting, to get misoprostol or a DNC when I thought I was pretty healthy at the time.
Yeah. And so I noticed that you mentioned the experience where your medical doctor didn't believe in this case, progesterone. Can you talk about what it's like as an educated and very skilled medical research person and asking for, at that time, I guess you were a graduate from naturopathic medical school, and asking for a treatment that is actually completely evidence-based, and that's progesterone is pregnancy hormone and it has a great safety profile. And how do you reconcile that a physician is the gatekeeper for perhaps that prescription, at least at that time, and doesn't believe in it, and that is applying a very dogmatic approach to something that should be very, very evidence-based?
Mm-hmm. Yeah, it's interesting. I spend a lot of time looking at like global perspectives in women's health, and Canada is one of the only countries where your family physician is the gateway to gynecological care. In almost every other developed nation, you can just book with a gynecologist, right? You don't have to see your family doctor. And so they end up being the primary point of contact for many hormonal conditions, which maybe that's where just our general dissatisfaction with conventional care and hormonal medicine comes. If women have PMS or PMDD or menopause or infertility or miscarriage, the first person they talk to is the same person that's treating ear infections and diabetes and cholesterol and hypertension. And so we have a little bit of a gap there where there is, and with fertility, time is of the essence, right? And so when women get a positive pregnancy test, it shouldn't be this fight to get the kind of care or support that they need, especially like you said, it's harmless. Things have evolved. So my son, who was my fourth pregnancy that year, is now 9. And so in 9 years or 10 years, the research on using progesterone has now exploded to the point where it would be, I would hope that my old family doctor has evolved, right? So that that's no longer even a conversation. But you can see how long it takes for something that's really well established in research to trickle down or public health, and that women often have to go outside the box in order to get the most evidence-based treatment, unfortunately. But that is hard to reconcile, that we would imagine that women can't get the kind of support they need, even though we know it's safe and even though we know it's effective. That's just disappointing. So it's encouraging now that naturopathic doctors, at least in Ontario, have the prescribing rights to offer progesterone to their patients. Like, to me, that was just like such a step forward for women's health.
Yeah. Let's talk about that, Jordan. So in your practice, you have a thriving practice in Burlington, and you treat a lot of women with PCOS and infertility and other hormonal concerns. And now if you're looking at, let's say it's a woman who's had a couple of miscarriages, is it kind of like protocol now that she just uses progesterone prophylactically from post-ovulation until either a positive pregnancy test and then through most of the first trimester and or until she gets her period? Or how do you approach that? Do you test everybody every time?
That's a really good question. And that, I think we're going to see that standard change probably like in the next 3 to 5 years, because we've just gained like new information about that. So some of the most, I'll use the word like heroic studies on using progesterone are doing it prophylactically giving it every month for 12 months to see what happens. And more of those women fall pregnant, and more of those women, or less of those women, miscarry, and more of them carry to term. Those are often very, I use the word like heroic studies, where it's unexplained infertility, and we're going to give them progesterone and heparin and aspirin and all the things.
Okay.
That's kind of where that evidence sits right now. We don't know for the woman with Hashimoto's or some other cause of recurrent miscarriage if giving her progesterone prophylactically is beneficial, but I'm also not sure it's harmful. And so that's kind of where we sit. But in the last, I would say 4 or 5 months, there's been 2 or 3 trials published on looking at progesterone levels and the likelihood of a successful pregnancy. And that's the first time we've seen that. We know giving progesterone is helpful, but we never knew if there was this cutoff, right? That like above or below was helpful or not. And in the last 2 months or 4 months, there have been 2 studies published specifically looking at progesterone levels. And you have to be like in the 15, 20, 30 nanomoles per liter range in order to have a successful pregnancy. And so there are many women who will ovulate and have poorer progesterone levels. And I think maybe that's sort of starting to point to the use of progesterone in every cycle or prophylactically. So we're getting there. It's close. We're like, we don't quite have the dots together, but it's close enough in my opinion that I probably would consider it.
So 15 to 30 minimum in the mid-luteal. Yeah. Okay. Yeah. That seems to be kind of like the functional range that practitioners may have kind of agreed on clinically. Yes. And it's always good to see that backed up. So is it that they're seeing correlations with lower than 15 and a higher rate of not getting pregnant or losing a pregnancy?
Yes.
Okay.
So actually the references for this particular issue, I actually just did a podcast on this. So my integrative medicine podcast, the latest episode is looking at miscarriage assessment, which both you and I are very passionate about. And it highlights those 2 articles specifically. So one was if your progesterone was above 35, that your IVF or ICSI, so intracytoplasmic sperm injection, procedure was more successful than if it was below 35, so less miscarriages. And then a subsequent study was if it was over 15, there was a greater or a lessened likelihood of miscarriage than if it's below 15. Where, I mean, typically if it's above 10, we consider women to have ovulated, and then we generally haven't been able to do much with those numbers like up until this point. But I think we're starting to learn that there's some cutoffs. I'd love to see that expand to conditions where we think women have progesterone resistance, like endometriosis and luteal phase defect, right? Like in those women, progesterone is not quite as effective. Their own progesterone is not quite as effective. I'd love to see some data on how we can support those women a little further. But we know that giving them progesterone at this point, even if we don't test their numbers, it helps.
That's very interesting. I actually haven't learned the term yet of progesterone resistance. So can you explain what the difference is between that and progesterone deficiency or estrogen dominance?
Yes. So endometriosis is probably the best example. And we know in those women that their cells are not as receptive to progesterone as normal endometrium. And so given the same amount of progesterone, they don't get the same result. So their receptors are different, and they have less receptors on their cell sites. And so they need like an exaggerated amount of progesterone to do the same amount of work, which we think is why giving them progesterone as a top up probably improves their outcome, because we're flooding the system with progesterone and sort of overriding the fact that those cells are a little bit resistant to it. So that would be different than, say, a woman who just has a poorer ovulation or luteal phase defect. Women who spot through that luteal phase, they may just not be making enough progesterone. And so that's different than resistance. The term estrogen dominance is not like uber scientific. And so I don't love relying on that, because we do know that like when there's big disparity between estrogen and progesterone, that may increase your likelihood of miscarriage. This is a 2018 study too. So this is new. But clinically, we don't know what to do with it, right? Like we don't know how to lower estrogen. All we know how to do is increased
Great
progesterone,
progesterone.
right? And so that sort of ends up being the fallback clinically for what we would do for those women.
Yeah. Yeah, that makes sense. And I think too, like in your practice, do you look at progesterone resistance versus that that not making enough progesterone or luteal phase defect, a term that we both hate. It just makes you feel so bad about yourself. But do you kind of go back when you're working with a woman then and try to work on follicle quality, given that those follicular sacs or units become the corpus luteum? Or do you just kind of say, well, given that this is the case, let's do the top up because we're not sure yet how to effectively, in an evidence-based manner, like target that corpus luteum?
We should be doing both. Mm-hmm. So almost all the evidence for luteal phase defect, true luteal phase defect, is antioxidants. And we think that's why it helps, because those antioxidants actually improve the woman's own ability to make progesterone. And we talk about that in the book, like the dietary strategies and the supplements for luteal phase defect are specific antioxidants that have been studied that make the woman make her own progesterone, which certainly that's a great goal. Yes, we have a wonderful option with doing a top up with micronized progesterone, but the underlying issue in those women is their inability to make their own progesterone. And I think if we treat both angles there, we're likely to have greater success than just slapping progesterone on the problem, even though that also works. Yeah, it's so fascinating, isn't it? Because with all these angles, and thanks to the literature that is available, as well as knowledge from traditional medicine like Chinese medicine, we have tools, and not talking about them with women is doing them a disservice. You know, I was astounded by the statistics of miscarriage actually globally in your book. And it's a problem that is devastating on the personal level, and largely there's a ton of potential to prevent it. Mm-hmm. Mm-hmm. It's true. Like we think, and I do see the culture around at least disclosing miscarriage or being open about miscarriage changing. Yes. I think when I had my miscarriage, I, sheepishly told 2 or 3 people. And I talk about this in the book, that once I told my family, I had aunts and grandmas and all these people come forward and tell me about all these pains that they had in their past that, as I didn't know. And it was shocking to me that this was something that we never spoke about. So I see the culture around that particular thing changing, right? Where women are a bit more interested in being open with or having conversations about. But I think at the rate that miscarriage happens, which is very high, we're starting to make that a normal experience, right? Mm-hmm. Versus recognizing that we actually can influence it. And we want to empower women to be part of that process so that they can get well assessed, but that they also know how they can be part of the change too, right?
Absolutely.
Yeah.
So let's talk about a few of those lifestyle factors that women can change. I wanted to bring up caffeine because I will admit that although I'm a naturopath,
I know that's a touchy subject.
It's touchy because we love it. We love it.
And you know what? So when I talk about miscarriage in the book, part of what I go through is to explain to women and practitioners that understanding where in the process the imbalances are is important for us to understand how to undo them. So where in the IVF cycle did things fail, right? Where along the process did we have a problem? Did you miscarry at 4 weeks or 6 weeks or 8 weeks or 10 weeks? Because it actually does change what those underlying challenges are. And so for caffeine, what I found so fascinating is where along the process of fertility did the miscarriage or did caffeine have an influence? So for alcohol, by contrast, alcohol hurts the egg, right? Alcohol is that's where the step in the process where the problem is. Our best data is from, and I know I'm digressing a little bit, but our best data is from IVF, right? With IVF, they're great for studies because we took chance out of the problem. We took a lot of things out of the problem, and we like literally made everything meet up to see if it would work. And alcohol actually hurts much earlier on in the process. And whether the male or female consumes alcohol in their last 4 weeks before an IVF, it actually is decreasing their success. So caffeine, by contrast, isn't hurting the egg. They're perfect eggs, actually. And so the one study that has really sort of dove into this, they called those types of miscarriage sine causa, right? So with Latin for no cause, meaning that there was no like reason for these miscarriages beyond the caffeine. And so they go on to hypothesize, and we don't quite understand it yet, but we think it has to do with blood vessel development, blood vessel constriction at the wrong time. That basically, while we're trying to grow new vessels and establish that connection, we're putting a drug in that constricts blood vessels. That may be actually influencing what's going on. But it's as little as 100 milligrams of caffeine, which is a very small cup of coffee, actually. And so for me, this was sort of quite enlightening. When I think back to even my miscarriage history, I've always been quite a caffeine drinker, addict. And that would have been part of my lifestyle then, right? And so thinking back to like some of those things that I wish I had known in those moments, so that I could have sort of put my my healthiest foot forward, right? But yeah, the caffeine data is not positive, and it needs to be. There is no safe limit. That was kind of the conclusion of those studies, that even as low as 100 milligrams caused challenge. It was dose dependent. So if you drank, 1,000 milligrams, you had a bigger problem, but we couldn't find a safe limit. And I think that was kind of the most important take home for me, that even the smallest amount of caffeine was influencing your likelihood of success.
Now I'm going to be like, you mentioned very humorously that, that one of your favorite things is when patients ask you, okay, so can I like drink if I get my period, or can I like have caffeine in the first half of my cycle or whatever? So I just want to know though, because being a questioner, in your understanding of the data, is there a difference between coffee and tea and chocolate and those kind of various sources of caffeine, or did they actually just evaluate any source?
Caffeine.
Of caffeine? Yeah.
It was just caffeine. I know. Yeah.
I think one of the things that's happening though with our overall love and a reliance on caffeine is that we are tired and we are running, and the fertility journey in of itself is very stressful, and it has a lot of early mornings, often a lot of appointments, a lot of taking time off work or maybe making up time for work, and we go to caffeine to kind of keep us going. So I've only noticed that since I had 2 weeks away and I happened to be in the amazing place, Hawaii, that I came back and I don't actually crave anymore. I'm not into it. Whereas literally in the past year, I don't know if I've gone a day without having at least a tea, and like relished it and felt a strong difference after in my like mood and energy and cognitive ability and ability to kind of do life. So how do we, because not everyone can take 2 weeks off in the middle of their fertility journey, although maybe that's part of the medicine. But how do you counsel patients to kind of ease into these changes when, we're so reliant, and actually most doctors will tell women it's okay to have 100 milligrams or less. And like published, like even Health Canada standards will say even in pregnancy, 100 milligrams or less.
Yeah.
So how do we go about this? And your tone in the book is so supportive and empowering for women. It's kind of giving them information and but how do we implement all of the suggestions and know what's right for us and what's going to be meaningful for ourselves as individuals?
That's a good question. The way I usually present it to patients, and I'll do this whether we're talking about fertility or any other health condition, is that, technically medicine and science are just numbers. It's whether the numbers are important that is up to them, right? So we can say doing this will change your risk by 30%, right? I can't enforce how meaningful that is onto my patient. It has to be meaningful to them. And so when patients start to ask, the little, can I have this now? What about here? But then there's Christmas, there's lots of those little, where we want to make concessions in their health plan that are derived, like they're getting away from what the best evidence suggests, right?
Yeah.
So if the best evidence says this, but you would really like to justify having a glass of wine at your Christmas party, that's a personal decision, not a medical one, right?
Yeah.
And so I just present the numbers and information to those patients and say, as far as we can tell, even 100 milligrams of caffeine is lowering your success and, by X percent, right?
Yeah.
If that number is meaningful to the patient, they will do anything to make that number go away, right? That miscarriage risk. And I find women on their fertility journey are some of the most empowered women, right? Yeah. And I think if I asked you to stand on your head every morning for 10 minutes, you'd do it, right? Mm-hmm. And so, but I think where we have struggled with integrative care is not having that supportive amount of research to justify what we say. Yeah. Whereas, from my perspective, and when I come at topics in clinical practice, I know exactly what the difference is if you drink or don't drink, or if your partner drinks or doesn't drink. Yeah. You guys get to make the decision if you want to drink in your last 4 weeks before your procedure, but here are the numbers that, that you can hopefully be encouraged that you're actually making a difference. I think, so to backtrack, I think that's what they need to know, right? Yeah. That what they're doing is meaningful and what they're doing is making a difference. It shouldn't have 12 supplements on your desk and not know what they're doing or not know, how they're exerting an impact. We should know exactly what every sort of component of their health plan is doing so that they feel really bought in to how their actions are creating change. And so that's how I do it. I also tell them to wean themselves off the caffeine, bit by bit.
Yeah. Well, and I love how your book gives them the why. Why is your naturopathic doctor asking you to eat a certain way or take a certain supplement or get a certain blood test? You give them all that, and then they can, they understand the difference or not that it will make in their journey. And when people understand why, they can implement the changes if they want that outcome bad enough. Yeah,
exactly. It's challenging when patients go home and they Google all the things you say if they're not evidence-based suggestions, because they will, your treatment plan or your health plan will be contrasted by things they find elsewhere. And that's where we struggle, right? And so I think the more we sort of sit in there's an incredible amount of evidence for how to support women on a fertility journey from a diet, lifestyle, integrative approach. Mm-hmm. If we sit in that research, that's proof enough for those patients to get bought into, why they're doing what they're doing, I think.
Yeah. And I think the idea too of understanding what's happening in that physiological level, that substance damages the sperm or the egg that will give the DNA to your baby that will form their potential for their entire lifetime, including into their adulthood, and maybe even copy stuff into the next generation after that. Yeah. And this is so empowering, right? And to know that you can make a difference not only to your fertility outcome, but to the health of your future children and the next generations of your family. And we're just scratching the surface on this science of epigenetics. But it makes sense to start today in ways that feel pretty good. Nothing that you're suggesting in the book feels bad to do. It might feel a little difficult, to not have your coffee, especially if you're, super reliant on it, or for example, you're asking them to maybe exercise and things like that, but it's things that make you feel good in the end too. And that doesn't lie either.
Yeah. And I'm sure you've experienced that with your fertility patients. It's when their whole health starts to shift that they have greater success. Right. Yes. We're not honing in. And I think that's where we look conventionally at how we've supported fertility. tell my patients, like, we can force you to ovulate and we
Yeah.
can force the sperm to hang out with the egg. We can't make you not miscarry that way,
Yeah.
right? We still are relying on the underlying health of the couple to carry to term.
Yeah.
And so that's why our success rates with IVF and other technology is so low, because we can only force certain parts of the issue.
Yeah.
But the actual like underlying health of the couple matters so much as far as like whether or not that procedure can be effective, right? And so the total health of the couple actually makes a huge difference in their success. And you're right, like I shoot for practicality, right? I don't like to take food away from patients when I don't have any science to suggest it. And so I think that the suggestions in the book are relatively practical and will produce like overall better health, and at least an overall better understanding of hormone health.
Yeah. And because we're talking about bringing life into the world and healthy life, the book's going to change the world. It's awesome.
Thank you.
Yeah. Thank you so much for this. I feel like we could talk for another 3 or 4 hours.
Probably.
So we'll definitely have to do this again. Will you post your links in the comments below on how people can get in touch with you, the link to purchase the book, and where they can learn more if they want to reach out?
Absolutely.
Okay. Awesome. Thank you, Dr. Jordan.
Thank you for having me.
Yeah, we'll talk soon. And congrats on the book. It's awesome.
Thank you.
Ciao. Thanks for watching, guys. Bye.